All right, good evening, everyone, and welcome to the American Academy of Emergency Medicine Critical Care Medicine Section's Pathway to Critical Care webinar series. And this time we're going to be focusing on the resuscitation subspecialty this time. So I'm Matt Carvey. I'll be moderating tonight's session. I'm current AAMRSA CCMS representative, and very delighted to have everyone joining us virtually this time. So tonight's webinar will be recorded to the CCMS webpage and YouTube and kind of all of AAEM's social media accounts within about 4 days. So please invite your colleagues to watch this amazing session. But without further ado, I would like to welcome our panelist for tonight, Dr. Cameron Waldman. Dr. Waldman is currently a fellow through AMC's or Albany Medical Center's Resuscitation and Emergency Critical Care Fellowship. Thank you very much for joining us, Dr. Waldman.
Of course, I'm so happy to be here.
Awesome. So, you know what, I just like to start out this, conversation with all of these kind of pathways webinars that we usually do. Honestly, like, why did you choose to do resuscitation? Have you lived in Albany your whole life and kind of like being there, or kind of what's your background and why did you choose this subspecialty?
Yeah. So I'm probably guessing my path to like a critical care resuscitation, adjacent field. It's maybe a little bit different than most people's. Like, I didn't start out my emergency medicine residency thinking that I was going to go into, wanting to spend time with like the sickest of the sick patients. I first, even like before medicine, was interested in like medical ethics and philosophy, and that's what I did undergrad in at the State University here in Albany. And then through there, kind of transitioned to medicine. So it was always kind of the humanistic, like emergency medicine resident. And but I think it was just sort of a part of the circumstances that I was in at Albany Med. We have a very critical care heavy program. And I think that just rubbed off on me a lot because so many of my favorite mentors and attendings were critical care folks. And I think you just mentioned that Luke Duncan, who is surgical critical care trained, was on one of your recent webinars, but he was like, one of my favorite attendings to work with. And when Albany Medical Center was coming up with plans to create this resuscitation and emergency critical care fellowship, not only did we get Alexander Bracey, who was trained from Stony Brook, who, was one of the institutions that was like the earliest creators of the resuscitation fellowship. So we had Alex Bracey come on board, but not only did we have Alex Bracey, but we also had like all these really great critical care trained attendings who are going to be a part of the fellowship too, and help kind of guide us through the year of, our fellowship. So as I was getting kind of towards the end of a residency and thinking about what I want to do next, this is just a skill that really started to speak to me. And I think part of the reason it spoke to me was because of sort of some of the failings in our healthcare system right now, which a lot of emergency departments are experiencing, which is, all of these critically sick patients who are boarding for sometimes days in the emergency department. And I think that our, foundational emergency medicine residency and training takes us, to be able to care for those patients, only to a certain point. And I think that kind of depends on the resident if you want to like take the extra mile to really, have a deep kind of understanding of what happens next after they're stabilized and after the disposition is set. And I just felt like I wanted more of that training. So that's how I ended up in this fellowship.
Awesome. Yeah, that sounds great. Yeah, it was nice to have your colleagues on a lot of these sessions and everything too. It seems like AMC is a pretty big powerhouse for critical care in general. So
yeah, I guess so. That's I've heard that like one thing Albany Med does really well is they have a lot of flexibility with the emergency critical care trained folks. So they let them kind of split their time between the ICUs and the emergency department. And I think for some reason I've heard that that's not too common, but we definitely lucked out. The emergency medicine residents at Albany Med lucked out from that. So we got a ton of cool training from them.
Yeah, that's so awesome. Which kind of, I guess, leads me into my next question is, you're a current fellow in this fellowship right now. So has there been any changes in the application cycle that you've noticed over the last recent years? I know this is the newest branch of critical care, but have there been any major changes to the application cycle? What does that look like? Kind of what's your opinion on that?
Yeah, it's really sort of exciting to be part of a new fellowship within emergency medicine. It's, been an interesting experience. But apparently it's like a very small group of people that are trying to get it, sort of like to become an official fellowship, an accredited fellowship. And with that comes all these different things. So there's like basically a small group of people, including Alexander Bracy, my supervisor, people from Hartford, Stony Brook, and I think there's like maybe a program coming up in U Michigan. And so people are talking right now about, I think it's supposed to be for this following cycle of making the process more standardized. So now I think it's just sort of program by program dependent, and you sort of have to reach out and know about the programs that exist. From what I understand, I'm not sure. I know that Albany Med's application is rolling at this point, but what I hear is there's plans next year just to make it standard and to have like everyone be on the same board with the same deadline and et cetera.
Gotcha. Okay, that's great.
Mhm.
So I guess here's the big question. What makes, I guess, a resuscitation fellowship so much different than a general CCM fellowship, neuro, MICU, SICU, anesthesia, etc.?
Yeah, I think there's a lot of differences, but I think a phrase we often will say about the resuscitation emergency critical care is it's critical care in the first 48 hours. So that's kind of like the catchphrase that we've been using. But the idea is that we get a little bit more extra training than the average emergency medicine resident. We get a little bit more training in taking a patient who's like recently resuscitated and taking their care into those first 2 days. And on the flip side, kind of learning how to do some de-escalation of care when appropriate. So in our fellowship, we spend a lot of time kind of thinking about not only just like the critically ill patients and resuscitating them, but we spend more time on sort of like special hemodynamic circumstances, like somebody who has like chronic or acute right heart failure. And what do you do in the resuscitation of that patient? And we kind of take a much deeper dive into those scenarios. And I think also part of it is an academic fellowship. So we're thinking about, how do we become the type of leaders who can be, helping to contribute to change in our departments. For example, one thing that my co-fellow is working on right now is an extubation protocol for our emergency department. And that's just not something that really has existed yet at Albany Med. It does exist in a few other places. And so it's something that we can bring to the table as resuscitation fellows and say, hey, like we're gonna make this protocol. It's gonna be better for our patients in the end. In the next 6 months or so, we're gonna be working with our ultrasound division to try to incorporate transesophageal echoes into our resuscitations, and that'll be something that'll be led by the fellows. So there's that kind of academic, like how to be the leaders in integrating the newest and emerging sciences and technology of resuscitation into the emergency departments in a safe way.
Yeah, gotcha. It's very interesting you brought up this de-escalation. I've never actually heard of that. Beginning in the
Yeah.
emergency department, you think about the general EM doc kind of stabilizing that critical care patient and whether or not they're boarding to get them to the next phase, whether or not it's adding a third, fourth, fifth presser, unfortunately, So
Yeah.
the de-escalation is very, very interesting thing that you brought up. And it's more beneficial for the patient in the end, you'd think as well.
Yeah, it's funny because like I think like a lot of us who train in emergency medicine, we are pretty comfortable with the escalation part of critical care
Exactly.
or critical interventions, and I found myself very uncomfortable in the first part of this year, like saying like, okay, like I'm gonna extubate this patient now. I'm pretty sure it's the safe thing to do. Even more so in like the pediatric emergency department, we had a very, very sick respiratory season, as I'm sure a lot of people did. And so, coming back on support for, infants and neonates and things is, to me, was like a really kind of uncomfortable process and something I did not have a lot of experience with in emergency medicine residency. So it's been really, really fun to kind of get to learn a little bit more about.
Yeah, absolutely. And you kind of brought up one point already about this de-escalation, but have you found any other parts of, doing the transition from emergency medicine residency to a resuscitation fellowship? Are there any other difficulties you've had kind of doing that transition?
Mhm. I think it's funny because we have a new program. This is a brand new program this year. And so like I think this is like my own personal like growing pains. But I respect a lot of my colleagues, and then going into this role and trying to like, when we have like a critically ill patient and we're on our resus shifts in the department, we show up kind of like as extra hands and to offer insights, kind of be part of the team as the patient's being initially resuscitated. And I think that it took me a little bit of time to like kind of find confidence in my voice and to say like, hey, like maybe we should pause on this intubation until the patient's more hemodynamically stable. Like I don't think it's emergent. And I think it's kind of funny, but I think that's also something I'm finding as a common theme of my resuscitation education is it's almost more beneficial all the time just to help the team pause. And there's almost always more time to, better optimize the patient for whatever it is. And, intubation or procedure or something, there's almost always a little time to pause and say, hey, like, we can get their blood pressure a little bit more optimized. We can do this, we can do that. And I think it took me a little bit of time to like gain the confidence to advocate for the patient in that way.
Yeah, absolutely. Yeah, that's definitely a difficult thing to do, especially when you know that patient's pretty critical right now. Just
Yeah.
taking that pause, which is absolutely so important to do. I'm just an intern in emergency medicine right now, and you're already recognizing the importance of that very important pause.
Yep. Yeah. Yeah. And I think it's especially too, it's been like a culture for a long time, maybe in emergency medicine to just, somebody comes in and they're not really handling their airway well. So, we're just going to intubate them and get the workup done. And now we have so many great tools and resources to kind of like give ourselves time in that process, like non-invasive ventilation and all these things. And so I think the field is learning how to take it a little bit slower when it comes to those kind of resuscitations. And I think that, this program, this fellowship in particular is like, we're learning about that and like, taking our time with these like things.
Yeah, absolutely. So I guess you're more than halfway done your fellowship now, aren't you?
Yeah, I'm about halfway done. We started in August, so I'll
Okay.
be done, August 1st.
Yeah, yeah. So what have you learned throughout this almost halfway done your fellowship? What does it look like so far? And what have you kind of, I guess,
Yeah.
bounced towards, I guess, from a critical care perspective?
Yeah, so we spend a lot of time in the first part of the year. The way it's set up now, and it's like again, it's an iterative process. So after me and my co-fellow Megan Lieb kind of get through this year, we're all gonna kind of sit down and talk about if we should change things or not. We spend a lot of time in the emergency department doing emergency critical care shifts, and then in this last part of the year, I spend a lot of time in ICUs at Albany Med. So we basically we'll cycle through all of the ICUs. So our like surgical ICU, our neuro ICU, our MICU. I actually did do a rotation in the CCU not too long ago. We were just talking before this, but starting tomorrow, I'm going to shock trauma for a month as like elective month to work in there. Something called the CCRU, which is like a receiving or transfer receiving ICU. So that's going to be a big part of my next 6 months. But then also some goals now that like we're kind of getting more and more comfortable in our roles clinically, hopefully to help usher on some projects within Albany Med, like the TEE and resuscitation. So that's kind of what we have planned for the next half of the year.
Yeah, absolutely. Do you feel like a year is enough for all of this?
So again, I think that it'll be interesting to see. That was honestly, just like full disclosure, that was part of my worry in doing this, is I was like, you might have this experience as an intern where you kind of learn, just enough to make yourself dangerous. And there's kind of like
Yeah,
different moments of that within medical education, like from like
yeah,
medical school to residency to,
yeah,
and so I like at the start of this process, I was like, I really don't want to do that. I don't want to be in a position to, just learn enough to make myself dangerous with like, I'm much more hands-on with the vent, for instance, than I was in residency now. Like, And part of that comfort is exciting, but there's also like in the back of my head, I'm like, definitely not going to get as much exposure to this as like, a MICU fellow would over 2 years. I think for me personally, and this being a new fellowship, I'm at least very cognizant of that limitation and of that potential problem. So a personal goal of mine is to, kind of like think about at the end of this year, like where my shortcomings are, and if I've, appropriately learned the skills to try to overcome some of those shortcomings. So for example, one of the things that's kind of a hidden benefit of this fellowship is you get like connected to resources and people that I didn't really realize I'd be connected to. So for instance, like we have a text group going all the time where we're like bouncing ideas off of each other. And that text group includes all of the critical care alumni that have gone through Albany Med. So maybe there's like a MICU fellow out in Stanford now who just graduated, who's in her second year, and she, will text us a clinical problem that's tough and everybody chimes in. So that has given me a lot of comfort, and like we're all in different time zones. And so literally there's always somebody responding to it. And so that has been kind of cool, like to realize that, I'm found in this fellowship and this network of people, a safety net and a way to continue my education, even when like the formal part of the fellowship stops.
Yeah.
So I guess this is my answer to your question. I hope at the end of this year, I'll be in a position to do more good than harm.
Right. Absolutely. Yeah. It seems so quick, but at the same time, that safety net is really nice to have,
Yeah.
I imagine for anyone who's becoming a new attending, a safety net would be nice.
Yeah. And exactly. And I also think like, again, we go back to this concept of critical care in the first 48 hours. And so I think the nice part about, emergency department, either ICUs or trying to do ICU care in the emergency department, is there's usually room to escalate if something, does get out of hand. And so, if a patient's like, really spiraling, you can have your ECMO consultants come down. And, I think the purpose of the ED ICU is almost like another level of triage. So if you have patients who are designated as ICU level care in the emergency department, and you are the ones who has eyes on these patients, you are in a much better position to be like, this person needs to be prioritized now to go upstairs. Whereas if they're just kind of floating without a designated team or person with eyes on them, sometimes I find that those patients can kind of get lost in terms of appropriate triage of who should get the next bed. So sometimes what I do on shift is I should show up, round on all the ICU borders, and then call our charge nurse and talk with supervision and say, this one really needs to go upstairs next. So there's that element of it too, where I think that if something is a little bit more complex and beyond my training, at least I'll have the mindset and I'll have, the type of positioning within the ED ICU environment to, advocate for them to get a higher level of care sooner.
Yeah, absolutely. And that's such a unique benefit of being resuscitation trained with all of these borders, like you said, needing ICU level care. And technically, yes, getting it down in the ED, but not having direct observation necessarily is a very nice thing to have. And easing that kind of transition period from the ED to the ICU that's very unique, So yeah, very nice to have. But so awesome. We got a little bit of a background of kind of like what the resuscitation fellowship looks like, what you've learned about. How has it evolved since its inception?
Yeah. So this is going to be a question that each EDICU program or resuscitation fellowship, I'm sure everyone's going to have a different answer for you of how it's evolved. Yeah. It's in its nascency here at Albany Med. So I think, right now it's evolving right before our eyes, and like every conference that we're at, or every meeting that we're at, and every emergency department critical care division meeting that we have, like it's evolving in real time. So I think that our short-term goals is to, again, be a sort of an academic force within the emergency department that can help initiate protocols for our critically sick patients, that give our other emergency department colleagues something to cling on to and to have as a resource to use with these critically ill patients. So that's one of our big goals. our other big goal is we're in the process of figuring out how to design and create a designated space for the ED-ICU patients to go to. So some hospitals will already have that. But Albany Med right now, it's like an ED-ICU in place model where they just kind of like stay where they are, and then we go to them as the ED-ICU team. So that's kind of exciting for us. And so like at the same time where we're kind of doing this model, we're talking about, okay, what's it going to be like when they come to us? And, how are we going to, train our RN staff to, be credentialed and to work on that team with us, and, all those kinds of considerations.
Yeah. It seems like a rapidly evolving field, which is really nice to see.
Totally. Yeah.
So, and there's so many roles for a resuscitationist in the ED. It's going to be a nice gap that's filled, and it seems like it's going to fill more and more gaps that we didn't realize were actually there before.
Yeah. This might be the unpopular opinion, but part of me thinks like, if my role becomes obsolete, that would be great. Like,
Exactly.
if we can have enough like ICU beds in this country and every ICU, patient can go upstairs immediately, like I am happy for my role to dissolve.
Yeah.
But until then, this is like the reality that we have.
Right, exactly. That's right. So the way I kind of like to, I'll have 2 more questions for you, but the way I kind of like to finish off these webinars is kind of just, a patient comes into your emergency department very critically ill. What does your care look like from the moment they come into the emergency department to dispositioning, I guess?
Mm-hmm. Yeah. So right now at Albany Med, the model is when there's a resuscitation, either attending or fellow on. So we are paying attention to the overhead pages. And so if a patient is coming into one of our resuscitation bays, or if it's a level 1 trauma, or really, those are like the priorities that we show up at the beginning and see how the primary ED team is doing, and sort of offer our help or insights as like another part of the team. If there's time, really any EMS call within the department, we try to look and just eyeball and just see if they're, somebody who's going to need like immediate resuscitation, or if they're like, have hemodynamic instability, then we stay. Once the patient gets there, it depends a little bit on the primary emergency department attending of like kind of how they want our help. But oftentimes, with these sick patients, as there's multiple things going on at once. So I try to kind of stand back and be more of a big picture person and make sure that things are getting there in a timely fashion, that, emergent blood release is happening, and that like, if it's master transfusion protocol, that it's, happening with the correct products at the right time, and that they're repleting the calcium and other things that are not necessarily part of the protocol.
Right.
So I try to stand back and have like a bigger level. So sometimes that even means like, I kind of hear in the ambulance bay that a patient is really, really agitated, and after a trauma, maybe a head injury, like I'm asking for a stick of ketamine from my nurse just to have in my back pocket to help support the resident when like they need it immediately. So I've really enjoyed that a lot, because like I've gotten to think about the big picture of resuscitations, kind of like in an immediate part of the patient's care. So then after that is happening, some of the emergency department attendings are happy then to kind of have me act as more of the immediate supervisor of the residents from the next step of the patient's care. So just like kind of like making sure things are getting back, reviewing the residents' orders, and adding on anything else I think is helpful. A lot of times my role, which I've actually really liked a lot, is kind of gathering more information, something that like, you usually have time to do in the ICU when you get an admitted patient, but don't necessarily have as much time to do in the emergency department. So I'm going into our, like statewide database to try to comb for information for the patient, calling family members, and then helping with the resident in their thinking, the patient by, supplementing them with this information, and then helping guide their medical decision-making from there. Then once the patient is like dispoed, and so let's say that they, after all the resuscitation, they still meet ICU level of care, then often we will kind of get formally roped in as a consult. And at that point, usually we're kind of like fully managing the patients as they're boarding in the emergency department.
Yeah, gotcha. And then you were talking about the possible transition up to the ICU. If you deem that they're, critically ill and needing an ICU at that point, you can kind of facilitate that happening a little bit quicker as well.
Right. So if you have if you had, 3 patients boarding for the ICU, one of them is a DKA who's like doing fine on the protocol and his like gap is closing. The other one is, on BiPAP, but kind of doing well on BiPAP, like a CHF exacerbation. And then you have another one who's like hypoxic to, 89%, despite 100% FiO2, ventilated, you try all your things, you're like paralyzing them, proning them, all these kinds of things, and they're still not working. And that's a patient who really should go upstairs and have like dedicated resources of the MICU.
Yeah.
So in those kind of cases, you just try to triage, and for those patients, I'll usually try to, advocate for the ones who I think should, get that next bed. Instead of just who's been there the longest.
Yeah, exactly. Very true. Last question from me. For a resident who's interested in, a resuscitation fellowship in the future, whether they be an intern, second year or third year, what do you recommend they do in order to prepare for a resuscitation fellowship?
Yeah. So, obviously spend a lot of time with like your favorite, either resuscitationist or intensivist, I think, and get a real sense from them about the pros and cons about like one, just working with, critically sick patients. And I'd say like, if you're at the very beginning of your career in emergency medicine, like intern year, and you find yourself, not liking those environments so much, I would just say, give it some time, because I think it's really interesting how, in a relatively short period of time, you'll kind of grow to love those situations. And I've heard that from like a bunch of different people, just like me, who started out not necessarily loving the sickest of the sick patients at first in the beginning part of my career. Yeah. But spend a lot of time with your favorite intensivists. And then I think, particularly when you're thinking about, or if you're possibly thinking about, resuscitation versus a more traditional critical care route, I would spend time thinking about, the parts of the ICU that you like. So if, you love kind of like the daily, more traditional rounding setting of like the ICU, and you kind of like really love that like longitudinal care and all of like the real nuances of critical care medicine, nutrition and like kind of like all these things and especially like, long-term de-escalation, then like, ICU is definitely the route. I think that the kind of person that resuscitation might appeal to in emergency medicine is this kind of person that still wants to work within a more traditional emergency department setting and really loves that environment, but would also love the opportunity to spend more time with the critically ill patients, helping improve their status, or getting more time with those critical care interventions and procedures and vent management, but still just loves the home of the emergency department. I think that's the kind of person that resuscitation would appeal to.
Gotcha. Okay. Yeah, that makes a lot of sense. And is there anything that, if a program director for resuscitation is going to look at someone's application and they're going to be like, wow, they are very fit for resuscitation fellowship, what would really stick out on their application?
Yeah. Well, again, like we've talked about this a little bit already, but it's such an early field that I think like there's a lot of opportunity to take whatever it is that, makes, whatever interest somebody has, and to, there's a lot of opportunity to sell it as a positive in resuscitation. Like, for instance, if you're, if you're interested in palliative care, but maybe also have a joint interest in critically sick patients, you can sell that as somebody who's like, I want to come to this program, but I also want to fuse that with my palliative care experiences and maybe make protocols for the hospital or the department about how to initiate palliative care early for the sickest of the sick patients who might benefit from it earlier on. Just as an example, but I think that there's just so much opportunity in this field right now to contribute that almost any adjacent interest in emergency medicine can help to grow this particular, new field.
Yeah, absolutely. No, great pieces of advice. I have no more questions for you, Dr. Waldman. Do you have any other kind of pointers that you want to give out and last pieces of advice?
I would just say, be on the lookout, reach out to any, like, including me. You can find my information on the Albany Med website, or just, get in touch with our department, but really reach out to people who are in resuscitation now, because it's such a small field. You might not, it's not as easy maybe to find information on what's happening, because I think like there are new programs popping up all the time and talks about new programs. So sometimes just people in the field and in the know might have a little bit more insight for the applicants about, what to pay attention to, what to look for. So feel free to reach out to the people in the field now. That's probably the best way to go for whenever you have questions.
Gotcha. Thank you very much, Dr. Waldman. Just got a few more things we'll mention here at the end, but really appreciate you being here tonight and giving a little bit more advice and recommendations into, a resuscitation fellowship for those that are kind of considering it as well. So love the advice you gave.
All right. Thanks, Matt, so much.
So, okay, guys. So just join us for some more future critical care medicine section events, where we'll be holding our monthly council meetings every first Thursday of the month, usually around 8 p.m. Eastern time. If you don't have my AAEM, oh, it's a tongue twister, emails, you can contact Kathy Yu at AAEM. She's at kuy@aem.org, and you can get all the emails for the section from there as well. But some of the other stuff we have coming up here soon is going to be more of these pathways webinars as well. Next ones are going to be involving anesthesia, critical care, and then neuro ICU after that. But thank you very much again, Dr. Waldman, and have a good night, everyone.
All right, see ya.